for the research plenary. It's great to have everybody in Calgary and enjoying some unseasonably warm weather. The objective of the research track generally, and this session in particular, is to highlight the best Canadian emergency medicine research of the past year. For this year's CAPE 18 conference, we received a record 401 scientific abstract submissions, and we were able to accommodate 338 research abstract and educational abstract and quality improvement abstract presentations. Each of these submissions was independently peer-reviewed by at least 3 peer reviewers, and managing that process of 1,200 or more peer reviews was very capably and ably done by Shanna Scarrow and Kelly Wyatt at the CAPE office, and we owe them a huge debt of gratitude. The 4 presentations we're going to hear this morning were the 4 research abstracts with the highest overall scores after this rigorous peer review process. The presentation this morning is going to be live streamed, and we're also going to be opening up our questions to questions from the Twitterverse that will be moderated by Dr. Dan Ting. His Twitter handle is @DanTing, and please use the hashtag CAPE18. We're going to start by introducing our first presenter. It gives me great pleasure to introduce our first presenter and this year's winner of the Grant Innes Research Paper and Presentation Award for the top scoring abstract of this conference from the University of Ottawa, Dr. Jeff Perry, who will be presenting a multi-center before-after implementation study of the Ottawa Subarachnoid Hemorrhage strategy. Please welcome Dr. Perry.
Great, thank you, Andrew. So it's a pleasure to be here this morning to present the results of our study. I'd like to acknowledge my co-investigators as well as funding from the Canadian Institutes of Health Research. I have no conflicts of interest to declare. So anywhere between 2.5% and 4.5% of all ED complaints are for headache, of which about 1% are due to subarachnoid hemorrhage. As a result, many patients are over-investigated with expensive, invasive, and frankly painful investigations. However, on the flip side, we know that in Ontario, 1 in 20 patients are misdiagnosed at the time of their first emergency department visit. This most frequently happens in those triaged with low acuity, so CTAS 4 or 5, or those in smaller emergency departments. Mortality with subarachnoid hemorrhage remains high, approaches 50%, and 2 out of every 5 survivors are left with permanent neurological deficits. Those with a delayed diagnosis often fare poorer. So the impact of the Ottawa Subarachnoid Hemorrhage Rule and the 6-hour CT rule have never been assessed previously. So in this study, so we previously have validated the Ottawa Subarachnoid Hemorrhage Rule to be highly sensitive, and we published this last year, albeit with relatively low specificity. We've also previously demonstrated that early CT, so within 6 hours, in this study had 100% sensitivity for subarachnoid hemorrhage. So in this study, we sought to estimate the impact of implementing the 2 rules on testing rates, so CT, LP, CTA, and as well as the ED length of stay, as well as confirming the accuracy of both rules for subarachnoid hemorrhage in a new patient population with acute headache. So this was a prospective before-after controlled study conducted at 6 high-volume academic urban Canadian emergency departments over a 7-year period. However, one of the sites did drop out of the study after approximately a year. They drastically scaled down all research because they're of increased clinical demands. So our intervention included rounds, orientation to individual physicians, pocket cards, posters, and requiring a special requisition that they had to complete, so indicating which elements of the Ottawa Subarachnoid Hemorrhage Rule were positive anytime they're going to order a CT head. They were able to override the rule, but they had to explain why they were doing so. So our analysis included univariate for investigations, length of stay, calculated sensitivity, specificity for both rules, and our sample size was 3,000 patients, including 180 subarachnoid hemorrhages. Our inclusion criteria were alert patients 15 years of age or older with a non-traumatic acute headache, Alert was defined as a Glasgow Coma Scale score of 15. Non-traumatic as no direct head trauma in the preceding 7 days. And acute referring to pain reaching maximum intensity within 1 hour of headache onset, and that the patient presented to the emergency department within 14 days. We excluded patients that were referred in from other centers with a confirmed subarachnoid hemorrhage. If the patient had 3 or more similar headaches in the past, if they had already been investigated for the same headache with both a CT and an LP, if they had new neurological deficits, either focal or global, if they had previous aneurysm, subarachnoid hemorrhage, or a brain tumor. So we define subarachnoid hemorrhage as blood on the CT, xanthochromia in the cerebrospinal fluid, or red blood cells in the final tube with positive angiography. So in the study, we enrolled 3,669 patients, consecutive patients. In the control phase, we had a little more than 1,700. In the intervention, 1,900, with a total of 185 subarachnoid hemorrhages. The final diagnosis, most commonly migraine or benign headache, which included tension headache. Cluster migraines are those that are felt to have a benign headache treated in the emergency with normal follow-up. Subarachnoid hemorrhage was 5%, and other serious causes were rare. In this slide, we show the characteristics between the 2 phases. They're generally quite similar, with the exception of thunderclap headache, which was more common in the intervention phase. This shows some more characteristics, including loss of consciousness, neck pain, stiffness, vomiting, arrival by ambulance, blood pressure, which were all pretty similar between the 2 phases. So this is one of the main slides here. So this is one of the money slides. So the CT rate did not appreciably change between the 2 phases. However, the lumbar puncture rate did go down quite markedly. It went down from 38.9 down to 25.9, which was statistically significant and clinically significant. The CTA rate went up a little bit, and the LP or CTA rate went down nearly 10%. The length of stay did not appreciably change, and admissions to hospital did decrease. When looking at just the patients arriving with and early who had a CT within 6 hours, so this was 1,200 patients. Here, the LP rate again went down from 31 down to 15%. The CTA rate didn't really change, but the LP or CTA rate went down with an absolute difference of 15%, which was statistically significant. However, mean length of stay did not appreciably change, and hospital admission rates went down. So looking at our second objective, so looking at the accuracy of the rules, the Ottawa subarachnoid hemorrhage rule did identify all 185 patients with subarachnoid hemorrhage, albeit again with relatively low specificity. When looking at the accuracy of early CT, there was 108 patients who met our definition of subarachnoid hemorrhage from the 1,200. The early CT identified 103 of them for a specificity of 95.4. So what about those 5 patients? Well, the first patient was actually a misread by the radiologist and subsequent reread by a blinded neuroradiologist. They identified the subarachnoid hemorrhage, but does go to show that radiologists may miss the bleed as well. There were 2 patients that were felt by the treating neurosurgeons to be incidental, but because of patient preference and concern, they intervened anyway. One of them was clipped, and they didn't have any adjacent brain parenchyma staining, which you would expect if there was a recent bleed. So that confirmed their suspicion that this was incidental aneurysm. And the other patient, they defined as unruptured, but again went in to intervene as a preventative measure. One patient had a dural vein fistula, which is a relatively rare cause of non-aneurysmal subarachnoid hemorrhage. And one patient had sickle cell anemia, known to always have pretty profound anemia, and on the day in question here, had a hemoglobin of 63 with a 3 millimeter aneurysm, which was coiled. So some limitations, well, First off, there is no gold standard definition for subarachnoid hemorrhage. We have been using the same definition throughout all of our studies, and basically think it was consensus-based and think it's a bit more conservative, so we may actually enroll or define some people with incidental aneurysm as subarachnoid hemorrhage, which it likely happened in these two cases. Physicians were able to investigate the patients according to their own clinical impression, so we weren't able to force them exactly what to do, although we pushed them a little bit with our requisitions. One site did drop out of the study because of clinical pressures. This was before intervention. We relied on medical record review for our 6-month follow-up. All of our sites did include neurosurgical sites, so we feel that is quite complete. And we did not exclude a priori patients that were anemic. In the radiology literature, it's actually quite well established that blood cannot be differentiated from body fluids if the patient's profoundly anemic, and maybe even up to 90, hemoglobin 90. So we ought to have excluded these patients before, but we did not. So clinical implications, Ottawa subarachnoid hemorrhage rule is indeed ready to use. High-risk patients should be investigated for subarachnoid hemorrhage. Low-risk patients should be managed symptomatically or investigated for other conditions. The 6-hour CT rule, I'd say, is reliable to diagnose aneurysmal subarachnoid hemorrhage. However, it is dependent on an experienced radiologist, and it should not be applied to patients known to be anemic. Patients that are low pretest probability with a normal early CT likely do not need more testing. However, those that have an early CT but are deemed to be at ultra-high risk clinically may still warrant a discussion with the patient or further investigations. So in conclusion, the Ottawa subarachnoid hemorrhage rule provides physicians with an accurate tool to investigate subarachnoid hemorrhage. The Ottawa subarachnoid hemorrhage rule will not reduce investigations, at least CT, but will help to standardize the investigations that are being done. The Ottawa subarachnoid hemorrhage strategy will decrease the use of testing after CT, so LP and CTA. And the 6-hour CT rule is reliable for aneurysmal subarachnoid hemorrhage, but does require an experienced radiologist, should not be applied to anemic patients, and may not pick up non-aneurysmal subarachnoid hemorrhage. I'd like to acknowledge the physicians at our study sites, my co-investigators, Kathy Clement, our research manager, and Angela Marcantoni, our research facilitator. Happy to answer any questions.
We have time for 1 or 2 questions from the audience. Or questions from the Twitterverse.
So the question is whether I have a preference for CTA versus LP post-CT. Yes, I would certainly promote a lumbar puncture as long as there's no contraindications due to the incidental aneurysms. Anywhere between 1% and 4% of the general population will have one. If you diagnose it, then most neurosurgeons are going to operate, because one, you're basically now living with a ticking time bomb in your head, and that's going to be distressing. And it's also would have to be a courageous neurosurgeon to actually say, no, that's incidental and I'm not going to touch it.
And one other question from over here.
Thank you. I was wondering how many low-risk patients went on to further investigation?
So how many of the low-risk patients did actually have?
Right, so if the patient was low risk, the physician could override that and go on to further investigation anyways, correct?
Correct. I don't have that exact number, although it was quite low. I mean, our overall investigation rate was about 87%. So there's actually a few in the higher risk group that didn't go on to investigation as well.
Thank you.
One last very brief question from the audience.
Very brief question. Your cutoff for anemia?
So in the radiology literature, it would say 90.
Thanks very much, Dr. Perry. Our next presenter is Dr. Stephen Friedman from Alberta Children's Hospital and the University of Calgary. He'll be presenting the second highest scoring abstract of this year's research abstract competition and the top scoring pediatric abstract of the conference, a probiotic regimen for outpatient gastroenteritis, utility of treatment, or the ProGut study.
Thank you very much, and it's a pleasure to welcome you all to a typical, beautiful Calgary, sunny, warm day. So it's a pleasure to present this study here at CAPE on behalf of the Pediatric Emergency Research Canada Network. This work is a reflection of collaboration across the country of all of our partner sites and all of the authors and investigators listed on the slide. I have to go through a couple disclosures. So the grant was funded by CIHR. I do have some funding from the Alberta Children's Hospital Foundation. Phil Sherman is a Canada Research Chair, and we had some in-kind funding from Calgary Laboratory Service, as well as some other partners who helped us with diagnostic testing that I'll go into. And Phil Sherman also holds honoraria from Abbott Nutrition, Mead Johnson Nutraceuticals, and Nestle Nutrition. The other thing is that Lalma Health Solutions, the manufacturer of the probiotic I'll be discussing, provided the study drug and placebo in kind. We have no conflicts of interest, and I've received no honorarium. I was told to add this slide in, I'm not sure why. And no mitigating potential biases because none were disclosed. So acute gastroenteritis remains one of the most common reasons children seek emergency department care. Nonetheless, we have very little that we can do to actually modify the disease course. While we can treat symptoms like vomiting, we actually can't necessarily change the natural trajectory of disease. But at the same time, probiotics is a burgeoning industry, estimated to worth $60 billion currently and expanding at about 13% per year. There's very little evidence supposed to support most of the recommendations, and many of the studies in pediatric acute gastroenteritis have significant methodological limitations, including focusing on individual symptoms, such as diarrhea to the exclusion of vomiting, or duration of diarrhea to the exclusion of frequency of diarrheal episodes. And they've generally been done in low and middle income settings where the pathogens and microbiomes differ significantly from what we see in North American children. Nonetheless, 5 of the 12 major guidelines published on acute gastroenteritis management have endorsed their use. Our hypothesis was that probiotic administration would result in a significantly lower proportion of children experiencing moderate to severe disease within the subsequent 14 days compared with placebo. So we conducted a randomized, double-blind, placebo-controlled trial in 6 Canadian pediatric emergency departments. Eligible children were aged 3 months to 48 months, and they also had to be clinically diagnosed with an acute intestinal infection defined by greater than or equal to 3 episodes of diarrhea in a 24-hour period, less than 72 hours of symptoms, and they may or may not have had associated vomiting. Exclusion criteria included presence of an indwelling vascular access line, structural heart disease, immunodeficiency or immunosuppression, and these apply to either the child or a household member due to the risk of bacteremia, presence of hematochezia or bilious vomiting, chronic gastrointestinal problems, pancreatic dysfunction, oral or gastrointestinal surgery within the preceding week, over-the-counter probiotic administration supplementally, so that does not include food products such as orange juice or cereal, but rather direct consumption of true probiotics, or soy allergy because the product actually grew in a soy culture-based medium. We used a web-based random number generating software system to randomize patients. It was randomize.net, employing random block sizes and a one-to-one treatment to active to placebo treatment allocation assignment ratio. Randomization was stratified by study site, and individuals blinded included the participants, their caregivers, study and clinical staff, specimen and data analysts. So the intervention included the administration of a probiotic named Acidafil, 4 times 10 to the 9th colony-forming units per sachet. It's actually a combination probiotic agent of a Lactobacillus rhamnosus R0011, as well as Lactobacillus helveticus R0052 in a 95 to 5% ratio. The placebo was identical in appearance, smell, taste, and weight. And each child received 1 sachet administered twice daily for 5 days. We followed kids daily and completed surveys every 24 hours until the vomiting and diarrhea had ceased for a complete 24-hour period. In all children, we also additionally performed a day 5 follow-up survey as well as a day 14 follow-up survey. These could have been performed either electronically or by telephone based on caregiver preference. Stools were collected throughout the study at day 0, day 5, and day 28. The enrollment visit stools, though, are what I can discuss if there are any questions. And we actually performed bacterial culture, a multiplex PCR 15 pathogen panel, as well as an in-house 5 virus RT-PCR panel. And this was performed to ensure that our patients were equally distributed in terms of their etiologic pathogens between both study arms. Primary outcome was moderate to severe disease within 14 days following randomization. We employed the modified Vesicari scale score, also known as the MVS, and a score greater than or equal to 9 on a range of 0 to 20 was classified as moderate to severe. Secondary outcomes included duration of diarrhea, duration of vomiting, unscheduled visits to a healthcare provider, as well as any adverse events. This is a description of the modified Vesicari scale score. We chose this because it actually encompasses 7 really elements that are paramount to the disease burden accompanied with gastroenteritis, and has previously been published in the literature and validated and used for most of the main clinical trials in gastroenteritis currently. And it focuses on diarrhea duration and frequency, vomiting duration and frequency, temperature, healthcare provider visits, as well as treatments administered. Each of these 7 elements is assigned a score of 0, 1, 2, or 3 based on the classifications that you can see here. The totals are summed at the end of the 14-day course, and we only focused for the outcome measure of the study. The score started at 0 at the time of randomization, so all outcomes included in this score were those that occurred in the 14-day follow-up period. Our placebo event rate was estimated to be 25%. We had identified an MCID of 10%, and we employed a two-sided 5% significance level and 90% power, and adjusted for several elements, including 10% loss to follow-up, 5% dropout, 2.5% crossover rates, and we employed O'Brien and Fleming monitoring boundaries, and that led us to a final sample size of 886 children. All analyses reported are through the intention to treat principle. We used multiple imputation to account for any missing data. The overall significance for the secondary outcomes was set at 0.05. And for our primary outcome, we employed logistic regression stratified by study site. Secondary analysis included other covariates. And then we also employed some subgroup analyses that were pre-identified and looked at interaction. As you can see on this slide, we assessed 2,663 children for eligibility. 1,777 met exclusion criteria, leaving 886 for randomization, with 444 in the probiotic group, 442 in the placebo group. Ultimately, 414 and 413 children in each group were followed up, reflecting 93% follow-up in both groups respectively. Patient characteristics were similar between both the probiotic and the placebo group. I'll just review the overall data to give you a sense of our study population. The median age was 16 months, 56% were male, 14% had been on antibiotics in the preceding 14 days, 6% were still exclusively breastfed, 49% reported having received the rotavirus vaccination at the time of study enrollment. The median duration of illness was 43 hours. The baseline MVS was 10, and the prior ED visits had occurred in 10% of the study population. And at the index ED visit, 22% received ondansetron, and that was similar between study groups. So when we look at our primary endpoint, looking at all participants, as you can see, there was no significant difference between the probiotic and the placebo group, with outcomes of 26.1% in the probiotic group and 24.7% in the placebo group having the outcome of interest, for an odds ratio of 1.06. When we looked at our subgroup analyses, we looked at children who were aged less than 1 year exclusively, which included 284 children, exclusively breastfed children, so 53, antibiotic used in the last 14 days, 110 kids, and compliance greater than 70%, which reflected almost 600 children. All 4 of these outcome measures had no significant difference between study groups, with odds ratios crossing 1.0. When we looked at several of our other secondary efficacy endpoints, including diarrhea duration, vomiting duration, and then healthcare provider visits, once again, there were no significant difference between study groups. Lastly, we looked at adverse events in our entire cohort of 827 children who had follow-up, and the odds ratio was 0.83, crossing the 1.0 mark as well. When we looked at the mean number of daily episodes of diarrhea, as you can see here, the probiotic and the placebo group, the probiotic is in the dark red, the placebo group is in the hashed shaded area. There were no significant difference between groups on any of the 14 days of the study, with an incident rate ratio of 0.98, with bounds of 0.85 to 1.13. When we look at the mean number of daily episodes of vomiting, there actually was a difference in the incident rate ratio here favoring placebo use, with an odds ratio of 1.36 with a 95% CI of 1.13 to 1.63. And as you can see, the greatest difference was on day 1 following randomization. However, I do need to point out the total number of episodes depicted on the y-axis was 0.8 in the probiotic group relative to 0.5 in the placebo group. So you're talking a difference in vomiting episodes of 0.3 per day, so the clinical relevance of that is really probably minimal. Lastly, when we look at secondary analyses of our primary outcome, we adjusted for study site. We had an odds ratio of 1.06 with 95% CIs of 0.77 to 1.46. We looked at other covariates included in the model. Once again, the odds ratio was not statistically significant. We then also explored the MVS, the Modified Vesicaria Scale score, as a continuous variable. And as you can see, the probiotic group had a mean score of 6.0, the placebo group 5.8 for a P of 0.44, so not significant between groups. The study does have some potential limitations. It's subject to recall bias, so our outcome measure was subjective reporting per caregiver report. However, we contacted them daily, and there's no reason to believe there would be a difference between either study group in their ability to recall their child's symptoms. We employed a composite outcome measure, which can be criticized because it does combine several elements into one score. However, as you can see, we broke down all the individual scores, including those that other studies have reported on, and found no difference in any of the individual measures of the composite outcome measure. We studied a single probiotic, so we studied a combination Lactobacillus rhamnosus helveticus combination, and all we can comment on in the reports of this study are related to that product and that dose. And lastly, this was conducted in Canadian emergency departments, where we are subject to Canadian local host microbiomes, as well as local infectious pathogens. So in conclusion, in children presenting to an emergency department with gastroenteritis, twice daily administration of 4 times 10 to the 9th CFU of a Lactobacillus rhamnosus helveticus combination probiotic does not prevent development of moderate to severe disease within the 14 days following randomization. Huge thank you to our program manager, all of our site coordinators, our study investigators, our student research programs at our sites, as well as our laboratory partners. Be happy to answer any questions.
Time for a couple of questions for Dr. Friedman.
So the question was, in the subgroup of children who received ondansetron, did the probiotics prevent or have a greater benefit? We actually haven't looked at that group of 20% that got ondansetron at the ED visit as an exclusive subgroup, if I'm understanding your question.
And any other questions from the audience or from Twitter? And so where does this fit in the scheme of, you said this was a multi-billion-dollar industry?
Yeah, so I'm not receiving fan mail from them. So the nutraceutical industry is a challenging industry. They can be great partners to work with, and the company that I worked with was a great collaborator, completely uninvolved and had no say in anything that we did. But having said that, it's an industry where I think the industry, as well as I believe Health Canada, need to change their approach to these elements, because I believe Health Canada needs to do a better job regulating. For those who don't know, anybody can market some probiotics that you grab out of your bathroom and put it in a bottle and sell it and call it a probiotic. And then you can make 4 claims: that it improves your intestinal microbiome, that it improves gut bacterial health, that improves your microbial balance, and there's a 4th one that I can't remember. So there's really no requirements for them to make these claims. And I think the big challenge will be, we studied one probiotic in this one, and it's impossible for CIHR or other government agencies to fund studies of all the ones that are out there. So I actually truly believe Health Canada needs to change the regulations and start requiring evidence to support the recommendations and their use, and the marketing. For if there's any family physicians in the room, they are knocking on your door nonstop. So I believe there's a requirement to change that so that they actually meet the requirements of drugs, because people are taking them. There are risks. There's the adult study of severe pancreatitis out of the European Union, where they had increased mortality in the probiotic arm. And then there's lots of reports of bacteremia associated with probiotics. So they're not as benign as one would believe, and I think we need to start regulating them better.
Thanks very much, Dr. Friedman.
Thank you.
Our next presenter is Mr. Akram Mokhtari. He is a medical student at Université Laval, and he will be presenting the third highest scoring abstract and the top abstract submitted by a medical student, a systematic review and meta-analysis looking at prophylactic administration of diphenhydramine to reduce neuroleptic side effects in the acute care setting. Mr. Mokhtari.
So, hello everybody. Start off to say that we have no conflict of interest, which is nice when you do like a systematic reviews that you can do research and being broke. So that's cool. So starting off on the subject, neuroleptics are commonly used in the acute care setting and especially in the emergency department. The problem is their side effects can be disturbing or even dangerous. One of the most commonly used agents to prevent those side effects is diphenhydramine. According to a survey of American physicians, 2/3 said they use diphenhydramine frequently in combination with neuroleptics to try and prevent those side effects. But the real question is, does it actually work? On one hand, this indication of diphenhydramine is off-label. More importantly, in the chronic care setting, where there's like more data on the subject, diphenhydramine is not recommended. The options that are generally recommended are propranolol or benztropine, high-potency anticholinergic drug. On the other hand, it's biologically plausible in the sense that diphenhydramine, because it's an antihistaminic and anticholinergic drug, should have an effect on neuroleptic side effects. Finally, it's pretty commonly used, so people seem to think that it does something. So with this systematic review, we sought to evaluate the level of evidence regarding this usage of diphenhydramine. So we searched the following databases as can be seen. We used the NO5A label of the WHO to ensure we captured any neuroleptic that basically ever existed. And finally, we used validated filter to ensure we captured only randomized control trial. What was our comparative in our study? Our comparative was any randomized control trial where there was an acute administration of a neuroleptic. On one side, the neuroleptic was combined with placebo or any inactive agent, and the other side, the neuroleptic was combined with diphenhydramine. Inactivity against neuroleptic side effect was defined based on label indication. What were our main outcomes? Our main outcome was any extrapyramidal symptom, which means anything that was related to the extrapyramidal system. And our secondary outcomes were akathisia, subjective restlessness, usage of rescue medication, and sedation. It is important to know that akathisia and subjective restlessness were included in the main outcome as a part of the main outcome also. We conducted a quality of evidence analysis with the GRADE approach. We used the Cochrane risk of bias method to evaluate risk of bias. And we conducted several subgroup and sensitivity analysis to evaluate for several factors, including dosage, age, number of doses, risk of bias, etc. So what were the results we obtained? There were 9 studies that were eligible and 8 were included in the meta-analysis. Studies were conducted in a variety of settings. 5 were conducted in emergency medicine, 3 in oncology, and 1 in gynecologic surgery. In terms of dosage, doses of diphenhydramine range from 20 milligrams to 120 milligrams IV, and the most common dose administered was 50 milligrams. Doses of metoclopramide range from 10 milligrams to 200 milligrams IV, and dose of chlorpyrrazine was 10 milligram IV in the 1 study that evaluated it. So 8 studies evaluated metoclopramide and 1 evaluated chlorpyrrazine as the neuroleptics. In terms of risk of bias, 5 studies were specifically designed to evaluate for neuroleptic side effects, and 5 studies were labeled as high risk of bias after evaluation. Now regarding our outcomes, for the main outcome, any extrapyramidal symptom, in the primary analysis, administration of diphenhydramine was not associated with a reduction of any extrapyramidal symptom. But there was a problem. This study, as you can see, the relative risk of the study is completely off the chart at 6.63, saying that. And we believe there were 2 main reasons for that. First of all, the comparative the study used was lorazepam, an agent that is not recognized as having effects on neuroleptic side effects, but according to the literature may still have some effect. And more importantly, the dosage of lorazepam that was used as a comparative was 2 to 3 milligrams, which basically in my case is can knock me out for 24 hours. So it's obvious I will not feel anything if I receive such doses. So we decided to conduct a sensitivity analysis to evaluate the impact of this study. In the sensitivity analysis, diphenhydramine was associated with a reduction of extrapyramidal symptom with a relative risk of 0.63. Now moving on to the second most important outcome, akathisia. In primary analysis, diphenhydramine was not associated with a reduction of akathisia. And in the sensitivity analysis, excluding the problematic study, diphenhydramine was still not associated with akathisia. Regarding all our other outcomes, none of them was associated in an increase or a decrease with administration of diphenhydramine. And regarding subgroup and sensitivity analysis, none of them yielded further information except one, the one where we compared the comparators. What we did compare in this analysis is that studies where diphenhydramine was compared to placebo to studies where diphenhydramine was compared to anything else. And as you can see, when compared to placebo, diphenhydramine was associated with reduction of extrapyramidal symptoms, but not when compared to anything else. So now we have 3 points of discussion. First of all, on strength and weaknesses, we believe that our main strength was the fact that the study was highly sensitive because we included indirect studies, but also every neuroleptic that ever existed. But our main weakness, we believe, is that many studies did not report the measurement methods for neuroleptic side effects. 4 of the studies did not report them, which is problematic in the sense that many of those symptoms are hard to diagnose and notoriously underdiagnosed, which may have affected our results. So now, on second point, the comparison groups. There are agents that are not recognized as having effects on neuroleptic side effects, but still may have some form of effect. A good example of that are benzodiazepines. Benzodiazepines were the comparator in 2 of the studies in the meta-analysis and 3 studies in total. The usage of benzodiazepines for this indication is off-label, but some data in the literature seems to indicate that they still may have properties. There's a small clinical trial and a few case reports pointing that way. So, because of benzodiazepines were comparator in some of the studies, this may have underestimated the efficacy of diphenhydramine. Moving on, last point of discussion, akathisia. Diphenhydramine was not associated with reduction of akathisia, but akathisia was included in the main outcome, which actually was statistically significant. And more importantly, akathisia, when we look in the literature, is notoriously underdiagnosed, which may have led to a potential non-differential information bias, which have undermined the association with diphenhydramine. Finally, what does this study actually add? First of all, like we said earlier, in the chronic care setting, they generally use high-potency anticholinergic drugs such as benztropine, which, and our studies seem to indicate that less strong drugs such as diphenhydramine may be sufficient in the acute care setting, which is interesting because diphenhydramine has less side effects than benztropine. Furthermore, diphenhydramine was not associated with the reduction of akathisia, which is interesting because the main reason often cited by clinicians to use diphenhydramine is actually to prevent akathisia. And lastly, diphenhydramine did not seem to increase sedation among patients, which is interesting also, because one of the concerns we saw in the literature is that there was a fear that diphenhydramine would increase the drowsiness caused by neuroleptics, which does not seem the case. Finally, very important point, overall quality of evidence is low, especially because at least 4 of the studies did not report how they evaluated for neuroleptic side effects, which is a significant problem in this specific situation. So, as a conclusion, diphenhydramine represents a cheap and innocuous option to treat neuroleptic side effects, but on the other hand, quality of evidence is currently pretty low, so we believe further studies are warranted to study the subject. Thank you very much.
We have time for a couple of questions, and I'd encourage people to use the microphones at the midpoint of the room. So there were some comparisons to other drugs. You had mentioned benzodiazepines. Were there other types of medications used as comparison besides benzos and placebo?
Yeah, and the comparison group, there was a study that was comparing the diphenhydramine to dexamethasone because it was a study conducted in oncology based on the anti-emetic properties of like metoclopramide. So the comparator was dexamethasone, but dexamethasone is not recognized at all as having any sort of effect against neuroleptic side effects. So that comparator was not a real problem.
Any questions on Twitter? Okay. Well, thanks very much.
Thank you.
And our final presenter and the 4th highest ranking abstract submission to this year's conference is from Dr. Alyssa Ness from the University of Calgary, who's going to be presenting a systematic review on the effectiveness of hospital avoidance interventions for elderly patients in the ED.
Good morning, everyone. Their names aren't up here, but I'm presenting on behalf of an amazing research team, a medical student from UBC, Michael Sierkowski, undergraduate students Nicholas Simons and Michael Broadfoot, as well as faculty representatives from the Department of Community Health Sciences, Emergency Medicine, and Geriatric Medicine. So Dr. Paul Rongsley, Carrie McBrien, Dr. Eddie Lang, and Jana Holroyd-Leduc. and I have no conflicts of interest to declare. So I just thought I'd open up with a case here. We have a 72-year-old man, CVA, residual deficits, aphasia, hypertension, AFib on Coumadin, primary aldosteronism, OSA. You see him in Emerge with hypertensive emergency. He has an MI, admitted to CCU. He gets lost to follow-up, no home care. His GP retires, and he's left without a family physician. You see him again in Emerge, this time with shortness of breath, and you've diagnosed him with CHF. You find out on further history that his wife is depressed after a significant family loss and has not been caring for him. Incidentally, there's a new lung mass found on imaging, and this is extensively investigated in hospital. Due to his lengthened hospital stay, he experiences a marked functional decline. And with all of the discussions about placement, the decision that comes to pass is that one of their children decides to move back to Calgary to help the parents cope. This is a story that we see here and there with our frail elderly patients. They happen to be at higher risk of acute care use, and when they do present to Emerge, are often admitted. When they are admitted, they experience a series of adverse outcomes. So prolonged immobilization, also known as bed rest, sensory overload or deprivation, whether they're in Emerge or in isolation on the wards, as well as medical interventions, so psychotropic medications, the use of restraints or Foley catheters, in order for us to provide the care that we believe they need. Unfortunately, this comes with side effects such as functional decline and a failure to return to their baseline, and transitioning repeatedly from the community to hospital results in a lot of care fragmentation. And families and caregivers who fly under the radar are sometimes left to pick up the work. We sought to answer the question, what interventions have shown effectiveness in decreasing Emerge use and hospital admissions in our elderly? Prior reviews were outdated or focused on interventional as well as observational studies, so we decided to focus on population aged 65 and older, experiencing acute illness and either facility living or dwelling in the community. We wanted to compare usual care to both provider and system level strategies. Our primary outcomes were emergency department visits and hospitalization, and secondary outcomes ranged from mortality to quality of life, patient satisfaction. We focused on interventional studies, randomized controlled trials, non-randomized studies, and controlled before and after studies. We searched Embase, Medline, CINAHL, and the Cochrane Central Register for Controlled Trials. We identified 9,559 studies, and out of these, 43 interventions in 44 publications were included. Full texts were excluded based on inappropriate study design, study population, or primary outcomes not of interest. These were reviewed in duplicate. Data extraction was performed in duplicate using a pre-identified data extraction form. So the studies ranged from 1995 to 2017. Altogether, there were 22 randomized controlled trials, so half of included studies were RCTs. About 16% were cluster RCTs, and the remainder were controlled before or after studies. 51% of the studies arose from the US, 25% arose from Australia and Spain, and the remaining quarter were from Italy, Sweden, Canada, Hong Kong, the UK, and Denmark. So just a general overview, you can see that a lot of the studies are coming from developed countries. Settings ranged from home visits, so half of studies employed home visits as a key part of their intervention. And then assisted living facilities were the other setting. Primary care clinics, there were a few interventions that also included telephone follow-up, so that comprised about 12%, and the remainder were in Emerge or in inpatient care with some telephone follow-up afterwards with the patient at home. Sample sizes ranged from less than 100 to over 1,000. I think the largest study group was about 8 million, utilizing population health data. Intervention types, they were a little bit difficult to categorize. There was a lot of overlap, but generally, half of studies employed home visits, as I'd mentioned, and with some mix of educational interventions. About 90% of these were targeted towards patients. A small portion, about less than 5%, were patients and caregivers, so patient-caregiver dyads, and then a small proportion targeting nursing home staff, physicians, or nurses on the wards. CGA over there stands for Comprehensive Geriatric Assessment. So these tended to vary from study to study, but generally it included physician assessment, a nursing assessment, physiotherapy, or dietitian assessment, depending on the professional components of the intervention. As you can see below, the intervention providers ranged from nurses to pharmacists and MDs. Multidisciplinary, I'll cover that in a subsequent slide, consisted of 3 or more professions. Duo tended to be an RN or primary care physician, RN physiotherapist, RN social work, and 1 primary care provider and case management study. So here we see the different variations of multidisciplinary interventions. They range anywhere from 3 professions to 5. And the other was just a very vague term of long-term care staff, and so I categorized that separately. Overall, study quality ranged from low to fairly high, and according to the grade framework, when we had assessed the global quality of evidence, would be moderate. Key findings that we took away from this study, because studies varied so considerably, we were unable to quantitatively assess the primary outcomes and secondary outcomes, so we categorized them as such. Home visits showed more statistically significant decreases in emergency department use and hospitalization. Telemedicine was categorized separately from home visits, so this made use of voice response monitors, telephone calls combined with remote monitoring, and then comprehensive geriatric assessment was assessed separately because there were some interventions where only a nurse would deliver this intervention, and other interventions where it was a team approach. So there were a few limitations of this study. As I mentioned, our PICOD criteria, we were only examining patients aged 65 plus. And it was brought to my attention that, because of our screening criteria, we excluded community paramedicine studies, which have proven to be successful in community, but their cutoffs for elderly were 60 plus. So in future studies, perhaps we would broaden that study population. There was wide variability across studies, so it was difficult to really perform any more rigorous quantitative analysis. This variability also was contributed to with the various countries and health systems that we looked at, which was a limitation, yet it was also a strength. I think it emphasized that North American countries were not alone in seeing this upsurge of complex patients in our emergency departments and in our hospitals. The other strength of this review is it was an updated comprehensive review, and it can serve as a framework for further intervention, refinement, and development. I think we tend to approach complex patients and think, okay, well, policy change needs to happen, but at the same time, seeing that interdisciplinary and multidisciplinary interventions have proven statistical significance in terms of their outcomes shows that perhaps we don't have to wait for these policy changes, that perhaps day-to-day practice on the front lines, when we pick up that phone, when we send that consult to social work, to PT, to OT, we are doing that interdisciplinary intervention without it being studied. So I hope this serves as an encouragement that those days where you see your consult list or your list of referrals pending as being long, that perhaps you're moving in the right direction. And this systematic review also could lend itself to supporting any policy movement in terms of funding complex interventions such as medical and social work being combined more rigorously and being studied more extensively. Thank you for your time and attention.
Time for a couple of questions for Dr. Ness.
Oh, sorry. I have a couple of results slides. Oh, the arrows, yes.
And maybe just to expand on this slide a little bit, there's
Yeah,
Uh,
a number
sorry,
of
it's quite
things that
small.
could fit within the groups of either home visits or
So,
telemedicine or education. Is there any signal that any particular type of home visit or home intervention is really
So-
effective?
The home visits that had showed the most significant impact on ED visits or had shown statistically significant results tended to be provided by more than one provider. So there were some studies that showed significance with just nursing visits, but we did see a little bit more effect when it was an RN plus an MD or RN plus social work. So I had classified those as duo studies and multi-intervention. So a nurse would conduct an assessment within the patient's home, and then a week later a physiotherapist would conduct an assessment within the patient's home, and then the patient would also follow up with their primary care provider in clinic. Telemedicine was largely delivered by MDs, nurses, and one study had shown a telemedicine assistant, which was a non-medical personnel but trained to answer ask an algorithm of questions. Education interventions, that was an interesting category. I had created that because so many of the studies had said plus patient education, plus caregiver education. It was rather vague, but they tended to be linked to studies that did show results, and so education has shown statistically significant effect.
Any more questions for Dr. Ness, or any questions from Twitter?
There's a question from Twitter. This is from Eddie Lang. Comprehensive geriatric assessment and home care do best at preventing hospitalization of the elderly. Is there evidence of cost effectiveness?
I'm glad. That's actually a very good question. There weren't very many studies that commented on cost effectiveness. There were a couple from the UK, I believe, and the United States. But in terms of Canadian literature and the number of studies that we'd come across with cost effectiveness, there wasn't very much that I'd found, unfortunately.
Any other questions for Dr. Ness? Okay. Thanks very much. So that brings our research plenary session to a close. I'd like to finish by taking the time to thank all of our colleagues who gave of their time to review all the abstracts that were submitted. Without their contribution and their work, the CAPE abstract program just wouldn't be possible. So thank you very much to everyone who took the time to review abstracts for this year's competition. I'd like to congratulate everybody who is presenting a research abstract at this year's conference, and in particular thank the 4 people on stage for their superb work that they shared with us this morning. Thanks very much.